My pleasure to introduce Dr. Samir Patel from Mayo Clinic in Phoenix, Arizona. Dr. Patel is going to talk about head and neck levels 3 and 4, and we'll have a chance to go over some cases and some contouring tips afterwards. Without further ado, Dr. Patel, thank you for being here, and we look forward to this time together.
Oh, thank you, Ben. Just a little bit about myself. I'm originally from Ann Arbor, Michigan, which is out in the Midwest of the U.S. And I've been at the Mayo Clinic for the last 9 years. And my main research interests focus on indications for proton beam therapy for head and neck malignancies, as well as I'm always looking at how we can mitigate toxicities for head and neck cancer radiation therapy. And I'm currently associate professor here at Mayo Clinic, and I always like to be accessible to everyone. At the end of my talk, I've given you my email address, and please don't hesitate to reach out to me anytime if you have questions. All right, so Dr. Hugh made my job rather easy. He did a great job giving an outline of indications for treating the neck, as well as outlining levels 1 and 2. And now we're going to be going on to levels 3 and 4, and I'm going to be a lot more focused on the anatomy on levels 3 and 4, how to delineate those nodal levels, as well as adjacent organs at risk. So what is the area that we're discussing at this point is, so you already talked about 1B and level 2. Now levels 3 and 4 are continuation of level 2. And another name you may hear about is a jugulo-digastric chain of lymph nodes. And these are what we're going to discuss. Recently, a large body of consensus papers have come out that have really helped establish some worldwide guidelines on how head and neck malignancies should be contoured, as well as their OARs and nodal level definitions, as well as this paper, which I'm referring to, which is the selection of nodal target volumes for definitive head and neck radiation therapy. So I'm just going to go over a few of these. Let's see, I'm going to move okay, there we go. In regards to oral cavity cancers, when you have a node negative neck, you're going to always cover 1, 2, and 3 electively. But you'll notice for 4A, when you have an anterior tongue tumor or oral cavity tumor that extends to the oropharynx, you're going to cover 4A as well. Now, when you have node positive N2 or higher necks, you're always going to cover 3 and 4. When you look at P16 negative oropharyngeal cancers, again, 3 and 4 coverage is indicated for all scenarios, regardless of nodal category. When you look at hypopharyngeal tumors, again, 3 and 4 always included. When you look at laryngeal cancers, again, I'm getting a little repetitive, but again, 3 and 4 are always included. So you're seeing, just as Dr. Hugh had mentioned, level 2 being a primary nodal drainage for many tumors, while levels 3 and 4 are included in that same chain. Now things change a little bit here with when you're looking at nasal cavity and paranasal sinus tumors. Typically the upper neck, 1B through 3, is included for node negative tumors, but you will include the entire neck when they're node positive. So let's move on to each individual nodal category. So when we look at level 3, the middle jugular lymph nodes, they receive their efferent lymphatics from mainly levels 2, which makes sense, and levels 5. Also, there are efferent lymphatics from the retropharyngeal, pretracheal, and recurrent laryngeal. And as I had already mentioned, you're going to consider this for majority of pharyngeal access or mucosal subsite tumors, and in addition, including considering it for thyroid cancers. So let's get into a little bit of interaction here I'm just trying to look at, can I just call on folks that I have listed here?
Yeah, or Rochelle maybe can also help.
Yes.
Okay, so who wants to tell me what the superior border for level 3 is?
Good morning and good afternoon. The superior border is the caudal edge of the hyoid bone.
Okay, and do you know what part of the hyoid bone?
Oh, sorry, the body of the hyoid
You,
bone.
you got it, that's right. So the caudal edge of the body of the hyoid bone. What about the inferior border?
The the caudal edge of the cricoid cartilage.
You're right, and we're going to go over this a little bit, but most guidelines do not tell you what part of the cricoid cartilage. I always use the posterior aspect because I think that's easily identified landmark, which I'll review with the group here. Anyone want to comment on what's the anterior extent of level 3?
It's the anterior edge of the sternocleidomastoid muscle.
Yep, you got it. That's right. I'll also show this, but also another landmark you can use is a posterior third of the thyroid hyoid muscle as well, when you get lower down in the neck. And then what about posterior edge?
It's also the posterior edge of the sternocleidomastoid muscle.
Yep, you got it. That's right. And then, just the lateral border, which I'll just mention is the deep medial surface of the sternocleidomastoid muscle. And does anyone want to try the medial edge?
Hi. It's the medial edge of the common carotids.
Yep, you got it. So the medial edge of the common carotid, as well as the scalenus muscle, which I'll review with here. All right, so here's a multiple choice question. What is the correct order of the cartilages from superior to inferior? A, B, or C? Because you need to know where these cartilages are located to be able to identify these anatomic borders for these levels. We got a lot of B? Okay, great. Yep, you got it. So that's right, B. Remember, the hyoid cartilage is the most superior. This is the sagittal, and then you have the thyroid cartilage, and then the cricoid cartilage inferiorly. All right, so what I'm pointing out here is, as you had also mentioned from, I believe Jason mentioned, was the anterior border many times is delineated as a sternocleidomastoid muscle, but there's always anatomical variations. And you look at the right neck here, you could easily see that's a nice anterior border here. But here you have this fat space here, and I'm always more inclusive than exclusive. And I would want to include this entire fat space here and not just stop at the anterior edge of the sternocleidomastoid muscle. This muscle is the thyroid hyoid muscle, and that was another anterior border where the posterior third could be another landmark. So that's just something to keep in mind about the anterior border. This should be self-explanatory. The lateral border is the medial edge of the sternocleidomastoid muscle. Posteriorly, you have the posterior edge of the SCM. Now, here we have the common carotid and the medial edge right here. Here we have the scalenus muscle. So just showing you kind of a rough outline of what a level 3 at this would look like. So moving on now to level 4A, the lower jugular lymph nodes is another name. And why is it split between 4A and 4B? So when they looked at a classic level 4 neck node dissection, they noticed that you never went all the way down to the manubrium for a level 4A neck dissection. And so they arbitrarily have set the caudal border. Now level 4A receives efferent lymphatics. Again, makes sense from level 3, the next step down from the same chain of lymph nodes, and then level 5. Uncommonly, but still does receive efferent lymphatics from the retropharyngeal, pretracheal, and recurrent laryngeal lymphatics as well. Again, now we're moving further down, and direct drainage into level 4 is most commonly from hypopharynx, larynx, thyroid, and cervical esophagus, and rarely anterior oral cavity. And as we had mentioned in that paper, that with oral tongue tumors, you can have skip metastases. And this is a paper from the University of Florida, I'm sorry, no, from MD Anderson, that looked at skip metastases, and they found up to 16% incidence of skip metastases where disease was only found in level 3 or 4, was not in 1B or 2. Therefore, many times when a surgeon, if they did a supraomohyoid neck dissection, which only includes levels 1 through 3, that's inadequate for an oral cavity cancer. Level 4 should be addressed. All right, so let's go back to more borders. Let's see. Anyone interested in taking on the superior border? I'll give you a hint. It's the inferior border of level 3.
Hello.
Okay.
Hello.
Question is about the superior boundary of the level 4A.
That's correct.
It's the inferior border of the cricoid cartilage.
Yep, you got it. So cartilage of the cricoid cartilage. And what would be the inferior border, which is that arbitrary boundary?
It will end at about the level of the clavicle.
Yep, this is close. That's close, but the definition is actually 2 cm cranial to the sternal manubrium. Okay.
Right.
So that is, you need to know the slice thickness of your CT scans. And this is the one that I mentioned that is arbitrary. What about anterior border?
It's the same as the level 3, the anterior border of the sternocleidomastoid muscle.
You're right. So the anterior body of the sternocleidomastoid muscle cranially, as you get down lower in the neck, sometimes the body of the sternocleidomastoid muscle becomes the anterior edge. Posteriorly, it's again the same, posterior edge of the sternocleidomastoid muscle cranially. And you'll notice as the scalenus muscle moves laterally, that becomes the posterior border and the caudal aspect. Lateral border is again the deep surface of the sternocleidomastoid muscle, but lower down it becomes the lateral edge. And then the same thing here, it's a little different in regards to the medial border. You have the medial edge of the common carotid artery, but also the lateral edge of the thyroid gland, the scalenus muscle cranially, and the medial edge of the sternocleidomastoid muscle caudally, and I'll show you this. So you have multiple borders. Again, there have been multiple actually contouring workshops that have shown that once you get into level 4, there's some variability that occurs in how you draw level 4, and there can be stylistic differences. It's not as well spelled out as the upper neck. All right. So what am I pointing at here? Yes, the esophagus. So why I point this out is because the cricoid cartilage is a completely encircled cartilage. And you notice that once you lose that posterior boundary and you see the esophagus bulging into the cartilage, that you've reached the caudal edge of the cricoid. Again, we have the anterior edge of the sternocleidomastoid muscle, the medial edge of the sternocleidomastoid muscle, the posterior edge. I'm pointing to here is the medial edge of the common carotid, as well as the scalenus muscle. And remember also the thyroid gland is right here. So here's my volume according to those boundaries. Now moving on to level 4B, the medial supraclavicular lymph nodes. Those receive efferent lymphatics, again, make sense from levels 4A, and then also from the lateral supraclavicular nodes 5C. There are also pretracheal and recurrent laryngeal lymphatics to those regions. Again, lower down in the head and neck are the primary sites that drain to level 4B, hypopharynx, esophagus, larynx, trachea, thyroid gland, and cervical esophagus.
Dr. Patel, we had one quick question about
Yes.
the inferior border of 4A being 2 centimeters above the manubrium. Is 2 centimeters above the sternoclavicular joint acceptable?
So the sternoclavicular joint or manubrium, yeah, I mean, the classic definition based on the consensus guidelines is the manubrium. But I'm going to show you on one slide that there's a lot of anatomical variation. In all honesty, if I'm covering level 4A, I'd rather over contour than under contour because I don't see there's a lot of toxicities in covering level 4B. So if you're under any uncertainty, you can always go lower down to the sternoclavicular joint or to the manubrium. And I think the additional toxicity is not that great. And I'll show a slide showing the anatomical variability when you look at 2 cm above the manubrium, how it looks different in many people.
Great, thank you.
So I know everyone's excited about these slides, right? And these questions right here. So let's try it again. Who wants to try the superior border for level 4B? That's the easiest one.
Haroon?
That's right. So that was what we just talked about was 2 cm cranial to the sternal manubrium. What about the inferior border? Yep, you got it. All right. And then does anyone want to take a guess at anterior?
Hi, good morning.
Good morning.
I think the anterior border of level 4V is also SCM.
Yep, so it's the deep surface of the SCM and the deep aspect of the clavicle as well that you can use as a guide. Posteriorly, does anyone want to take a guess? So I'll show the posterior border here. So this is basically, there's multiple structures you look at. You can use the scalenus muscle, which is you use more cranially. As you go lower down, the apex of the lung and the brachiocephalic vein and trunk on the right side, and the common carotid artery and subclavian artery on the left side are used caudally. The lateral border, now here is actually the lateral edge of the scalenus muscle, and I'll show that on a scan. The medial border, again, is adjacent to level 6, the pretracheal lymph nodes, as well as the medial edge of the common carotid artery. Now, actually, one thing I wanted to ask is, what's the most common type of pharyngeal axis tumor you see in the head and neck in the Philippines? Is a nasopharynx cancer common?
Yeah, I think like nasopharyngeal cancer is the most common, is more common than oropharyngeal.
Right, so this is another area where you're always going to cover level 4B and 5, but I think you're going to have a separate talk by Dr. McGee on level 5. Yeah. All right, so let's look at this scan here. So now, this is the sternocleidomastoid muscle. Okay, it's moved all the way medial and anterior. Okay, so just be mindful that it is not going to be located down here on the side. It actually moves anteriorly and goes medially here. We have the subclavian artery here, vein. We have, this is the scalenus muscle. Where it was here before in the head and neck, now it has moved laterally and forms that lateral border. there's the medial edge of the sternocleidomastoid muscle, the medial edge of the common carotid artery. So this is what your volume can look like. This is how it would look on the right side. So there's also special circumstances here with, I believe Dr. Hugh Turner had mentioned neck dissection and also extranodal extension, as well as also anatomical variations that you can vary, which I'll go over here. So here's an example of a gentleman that's had a right neck dissection. So while I would keep on the left undissected neck, I'm treating electively, focused on the borders we've discussed. In the right neck, I'm going to cover the entire SCM, and you've seen I've placed a wire on the neck dissection scar. And also, everyone has different amounts of subcutaneous fat. Now, if your CTV extends right up to the surface, what did Dr. Hugh mention last talk that you can do to ensure you have adequate dose to your target volume? Add bolus, you got it. So you add bolus if you need to.
That's an important point. And
yes.
We have another question for nasopharyngeal cancer, just clarifying, do we extend up to 4B?
Yes, I always extend to 4B. You're covering the supraclavicular lymph nodes, which include 4B and 5 fully.
Thank you.
Now, next slide. Okay, so now this is what I was referring to in the previous question. This is 2 cm cranial to the manubrium in 4 different patients. So you can see how the anatomy varies based on the patient's habitus. You know, some people have shorter necks, right, or different anatomical variations. I always, if I am uncertain, I will always go down to the manubrium. Any questions on that? Yeah, and feel free to type it in. Okay. So moving on now to OARs. So we have these are some of the OARs that are in the vicinity of levels 3 and 4. You have the pharyngeal constrictor muscles. You have the supraglottic larynx, glottic region, the cricopharyngeal inlet, the cervical esophagus, and the brachial plexus. I've included the anatomical borders here. I'm not going to read every single anatomical border to you, but we're going to review on the intergroup consensus supplement document, which I'll pull up in a second here. Before I do that, I also wanted to share this supplement with you. This is a step-by-step contouring of the brachial plexus. The brachial plexus is one of those structures that many dosimetrists, residents, physicians, they all dread drawing. But I believe these steps break it down very nicely. If you're able to systematically locate the C5 root at the intervertebral foramen between C4 and C5, remember the cervical nerve roots exit superior of the cervical body, except for C8. You locate the anterior medial scalene muscles. You contour the space between those muscles from the foramina to the lateral border of the muscles. And on the cuts where there's no intervertebral foramen, the medial border is just against the bony vertebral body. You continue down the same, all the way down to C8, which of course, as I mentioned, exits now inferiorly C7 and to C7 and T1. And then below C8, you start seeing the subclavian artery. The brachial plexus runs posterior and lateral to the subclavian at this level. And then you will also need to add in the T1 nerve root, which exits between T1 and T2, that goes around the apex of the lung. I'm going to show this to you, but this takes some practice. All right, so now let me pull up the supplement. Can you see the supplement?
Yep.
Okay. So first, let's start with the pharyngeal constrictor muscles. So superiorly to level 3, the pharyngeal constrictor muscles were extending to the base of tongue. But you'll notice right when you start seeing the hyoid bone come in, it becomes flat, straight across. So that makes it easy to identify right there. Now, if we go back up superiorly, the epiglottis is part of the supraglottic larynx volume. You're including everything anteriorly as well as the area epiglottic folds and the paraglottic space, but you're not including the air space. As soon as you're going down and you see the arytenoid cartilages, now you've transitioned to the glottic space. The glottic space continues along the arytenoid cartilages, and you'll see the small remnants that extend just medial to the thyroid cartilage there. And posteriorly is the cricoid cartilage. Right at the bottom aspect of the arytenoid cartilages, the pharyngeal constrictor muscles transition to the cricopharyngeal inlet. That extends down 1 cm below the caudal aspect of the cricoid cartilage. Then goes into the cervical esophagus. The thyroid, is easily identified flanking the trachea here and the inferior aspect of the larynx. Now let's look at the brachial plexus. If we go all the way up, come slowly down here. Now we have the C5 nerve root coming out, and this is the anterior and the middle scalene muscle. So that was, you're drawing between those two muscles, that space, just extending to the lateral border. Once you lose the foramina, you just draw right up to the vertebral body. And then you go down, and then as the foramina opens up again, you have the nerve root connect back up here, and then you keep repeating that. Now, as you go lower down, this is where the brachial plexus starts following posterior lateral to subclavian. Okay, this is the T1 nerve root right here, and now is extending posterior lateral to the subclavian. You can see that space right there. Now, what kind of dose tolerance would anyone use for the brachial plexus? So you'll see people will use anywhere between 60 to 66 gray. Here in the head and neck, I use a point dose, a max dose of 66 gray to the brachial plexus. But now if I have a lymph node here in level 3, I am still going to deliver 70 gray to that lymph node. I am not going to reduce my dose to try to spare the brachial plexus there. All I will do is counsel the patient on potential risks there. So that's an important thing to note, is that when you need to cover these lymph node spaces and you draw your OARs like the thyroid and such, I'm not going to worry about trying to spare the thyroid gland or the brachial plexus. I need to draw up to those borders and accept my tolerances. Now, especially if these are high risk or intermediate risk CTVs.
And Dr. Patel, when you've had those cases where you've had to cover lymph nodes with a high dose, have you been able to correlate that with any long-term toxicities of patients complaining about arm weakness or loss of sensation?
Yes, you bring up a very good question, Ben. Is with all the hundreds of head and neck radiation patients I've treated, I can't count on my hand the number of brachial plexopathy cases I've seen. I've not really seen a lot of brachial plexopathy. I've actually seen more, brachial plexopathy with breast cancer cases where we're offering reirradiation. That's and that's a good question we don't really understand. Maybe do the upper plexus of the brachial upper nerves are a little bit more tolerant of radiation, but there used to be this old teaching, and this was also seen in the cooperative group RTOG studies, that if you have lower neck lymph nodes, treat those to only 60 gray and then perform a planned neck dissection. We don't do that anymore, and I don't see any brachial plexopathy. It's a good question. Now, let's see, what did I have? Moving back to my presentation here, basically I just wanted to mention that levels 3, 4A, and 4B are a continuation of the jugular chain of lymph nodes. The borders are guidelines. Remember, there's always going to be anatomical variations, and you sometimes will need to use clinical judgment. Do not compromise target contours, particularly your CTV high risk, to avoid overlap with OARs. And here's my email address, and please don't hesitate to email me anytime if you have questions. Now I'm going to pull up the cases here. I had one case already pulled up, but actually let me go back to make sure I pulled up the right version here. Okay.
And you see these example ones. So for 8, 15, 18, you should be able to go into those.
Oh, excellent. Okay, thank you.
Let's see. We have one question, Dr. Patel. It's a theoretical question. Do you think the degree of neck extension or flexion would affect the borders of nodal delineation?
They can in the low neck. They definitely can if you hyperextend the neck. We tend to use a neutral position when we simulate our head and neck patients. If I'm treating a low neck patient, sometimes I'll use slight hyperextension. Now with intensity modulated radiation therapy, we're not worried about clearing the shoulders as much, but yes, it could potentially change the borders, and that's where you have to use a clinical judgment. Also, I've seen plenty of people with no neck, right? Pretty much the head goes to their shoulders. But if you're ever, my teaching has always been, if you're ever uncertain, it's okay to include a little bit more than less.
Thank you.
All right, so now I'm pulling up the CTVs here. This is patient 8. And
just a reminder, I think this is a T3 N2 nasopharynx case.
Okay, yes. So what I wanted to show here is you had already a talk about expansions, correct, in regards to GTV and CTV. And in this scenario, they had a positive node, and you have your CTV high risk, and then you have your CTV intermediate that's following the lymphatic space here. But then they have the CTV high risk with no further expansion. And I believe that you should always include additional margin on your CTV high risk for microscopic extension. And so if I had a CTV intermediate here, the safest thing is, if you're worried about a lymph node invading the SCM, is to include the entire SCM. Once you become more experienced or you feel more comfortable, if you have good treatment planning CT, you're able to have contrast or a planning MRI, you can start getting a little bit more focused with your volume. So in this situation, if I wanted to edit my CTV 59.4, let's see, oops, do I have to draw the whole thing, or can I crop it?
Just close it to the green dot. Yeah.
There we go. This is, so you could do something like this. I would add a minimum of 5 millimeters beyond my CTV high risk. but anywhere between 5 to 10 millimeters is considered acceptable. Same thing on this side. You could cover. I'm not as worried on the medial aspect. You don't see paravertebral muscle invasion as much, but if you're worried about medial invasion of the paravertebral musculature, then you would also want to include that. Now going down, I just have some notes here I'm looking at. All right, here. So now we talked about what's the anterior border here? Does anyone want to take a, you can unmute your mic or just type it. What's the anterior border here? Yep, you got it. So here's the anterior edge of the SCM, right? So here, you would want to include that. Same thing on this side. Now going down, someone brought their volume anteriorly, and then, oh, this is what I was going to mention on this slice. Someone included the scalenus muscle here on this slice and then comes off of it. Usually you're not worried about scalenus muscle invasion, but this is just a point that you want to be consistent with your target volumes. And once you're done drawing them, you want to scroll superior and inferior, making sure your volumes are consistent, following those borders. Now going down to here, again, anterior border, right? Now we're getting into the low risk neck. We want to include up to the SCM right here.
And it almost looks like a little sliver or a little finger pointing. Mm-hmm. Maybe
you got it. Yeah, I can draw that right here, right here.
Okay. Yeah, in the yellow.
Oops, I used the wrong, but the yellow. I can maybe delete this, right?
There's a little eraser at the top.
Oh. Yeah, you can see I'm not very good at this. I'm used to using Eclipse, so I'm trying to use Eclipse.
This is great. You can just click escape to exit, and then there's a little eraser.
I see. Right here.
Yep.
This one?
Yep.
Okay. There we go. All right. One more thing I wanted to show on this case is here. So what's the medial border of level 4? Yep, so medial edge of the common carotid, right? Yep, you got it. So right here, you see this volume's going right through the carotid. So just these little things here, making sure you're consistent with your volumes there, okay? Let's go to another case here. Example 15 here.
And we have two other questions. One is, are we strict in just including the fat space between the SCM and the thyroid, or can we include the posterior part of the SCM?
And I'm sorry, maybe I'm misunderstanding.
Jason, if you want to unmute your microphone, you could ask the question.
Sorry, in extending the contour anteriorly. So usually the fat space is very thin. So can we include a posterior part of the SCM, or we just include the fat space extending anteriorly?
Usually we cover just the fat space, but sometimes it's so thin, you may include a little bit of the SCM.
Okay, thanks.
Yep.
Yeah, sometimes my fingers look very, very skinny.
Yeah. You bring up a good point, Jason, that, again, these are guidelines, and sometimes, they pick very model patients to show these, and you may extend sometimes into muscle to cover these spaces. All right, so now this is a case where, let's see, go to slide 69 here. So again, just showing how the expansion is kind of like more of the traditional expansion that we'd like to see beyond the CTV high into the SCM. So that was good. If we go down to slice 105. So now when we look at the medial border here of this lymph node space, you see how we're drawing right into the scalenus muscle here. So Let's see, I don't know if I can pan this down, can I? Yep, okay. Oops, let's see, let me escape.
Just, yeah, if you connect the red dot to the red dot, it'll...
I'm thinking too hard. Oh, okay, so there you go. So just showing how you don't need to include the actual muscle in your lymph space. All right. The one thing I wanted to bring up is you notice how superiorly here, the anterior border is extending to the anterior edge of the sternocleidomastoid muscle as well as the posterior third of thyroid muscle. As we go down, do you see how it just all of a sudden stopped? It was here is covered, now it stopped. And then they started covering anteriorly again, right here. Again, just the point is needing to be consistent, right? To cover that space. That's important. All right, now let's go down to here. Someone want to take a look and let me know what do you see wrong in the left, just here in the left neck? What would you adjust? Well, I know we're running a little short on time, so maybe I'll just start drawing. So we want to include the common carotid, right? There we go. All right.
And we have another question. Now that we're at this level, are we concerned about the fat space between the carotid and the esophagus? Would you contour it, or would you stop at the medial edge of the carotid?
I would stop at the medial edge of the carotid. Again, this is another level here. This is level 6, right? So this is the level 6, the paraglottic lymph node space, which if you're concerned about extension there, or if you have positive level 4B lymphadenopathy, you can always include it. The reason why you just don't want to make it a routine to just include that fat space always is because then you're just increasing the risk of esophagitis.
Great, thank you.
All right, one more patient. Let's see if we can get it done. We got 3 minutes.
Yeah, this has been wonderful.
Let's see here. Again, I'm going to pull up our CTVs in this case. Now, let's go down. Okay, so just bringing up the point again. When you have your CTV high, this disease, you're concerned about it extending the sternocleidomastoid muscle, make sure you have the appropriate expansion. I know I keep going on about that, but it's very important to include any potential microscopic extension. And it's very routine for us to even consider covering the entire SCM here. And if you were, as you notice there's little fat here, you would just need to add bolus. I think in this situation also, you want to follow your CTV highs and look at the imaging carefully. In this situation, there's a lymph node here, and then you see how it's missed right here? There's a lymph node here that's not included. Just want to bring that out. Now, let's go to 102. Okay, so now the contour transitioned from intermediate risk to low risk here. Have we, which would be in this situation, you're starting level 4A, right? So from level 3 to level 4A, we talked about the inferior edge of the cricoid cartilage being a transition point here. Well, we have not reached the inferior edge of the cricoid cartilage yet, right? Right here, right? So this is where you would start level 4A in your low risk target volume. So just a little bit higher than I would transition.
And we have another good question, kind of related to what you were talking about the bolus. For a lymph node that's very, very bulky, sort of pushing right, obliterating the fat space, we recommend the bolus in order to deliver an accurate and high dose of radiation close to the surface. Would you put the bolus on at the start of simulation, or would you put it on after planning?
Very good question.
Wondering
It's,
about issues in error positioning.
yes, so it's always ideal to plan ahead at simulation and have the bolus placed under the mask. That's our standard of care at Mayo Clinic. But there are times when you are planning and you did not anticipate it. Then you have the option of adding the bolus on top of the mask, but then you don't have good skin contact. Or the other option is to re-simulate the patient. But yes, it's ideal to place the bolus at the time of simulation.
And do you use physical exam to help guide you in that decision? Or, oh, actually, I mean, I think what I use is I look at their imaging that's most recent.
That's right. So I would use the physical exam and recent imaging. It's always ideal if you have the option and have access to MRI. I like for definitive cases also using a treatment planning MRI. And that really helps even better delineate extranodal extension. And then this slice is just showing how the scalenus muscles are included in the target volume. So again, I would not usually include them inside our target volume. I would just carve them out. Okay. And I think that covers everything. I mean, everyone asked very good questions. Again, this was this last slide I had was this was just a carotid again. Just be sure to include the carotid. Well, I really appreciate everyone, the Rayos Contra Cancer, giving me the opportunity to give this presentation to these eager residents learning head and neck cancer. It's not easy, but again, I gave you my email address, and please don't hesitate to reach out to me with any question. There's no question that's silly, so please ask anytime.
Excellent. Dr. Patel, I'm going to say my official thank you after there's one more question.
Sure.
So one resident wanted to clarify, do we include the whole SEM on post-neck dissection cases?
Yes, that's a good question. So I always include at minimum the medial half of the SEM. But to be safe, if you're unsure, just include the entire SEM. The reason why why I sometimes try to just include the medial half is if I'm not worried about extranodal extension at that level, or I trust my surgeon that there is no tumor spillage, then I can maybe reduce some of the risks of neck lymphedema by not treating the superficial aspects.
Great, thank you. Well, now I want to say my official thank you, Dr. Patel. I appreciate you taking the time to go through the anatomy patiently. I think we hear these names and borders so frequently, but like so quickly in passing, we don't have time to actually digest and see and recognize. Also, going through the OARs very carefully, I think will be very beneficial. And lastly, the way you showed us real examples and stressing some important take-home points. Number one, you want to be consistent with yourself. I saw a lot of slides, people were doing the right things, but then when you scroll up and down, you may be being a little inconsistent. And then number two, knowing the borders, where it's important to have coverage and where it's also important that you can spare, like level 6, for instance, not always needs to be covered. And your patients could get through treatments a lot better that way.
Yeah, no, thank you. Well, I think, yeah, look forward to participating more. And thank you again to Ben for this wonderful work. And this is great.
Thank you to everyone. We're very excited to be with you.